Hi, this is Dr. Mahadevan, and I have with me an expert in trauma care, surgeon Dr. Kristen Staudenmeier, and we're going to do initial management of trauma patients, our expert analysis. So let's get started with our first case.
No! Michelle.
Oh my God, look out!
So a car crashes into a coffee shop. One of the nurses happens to be there, and she accompanies the patients to the emergency department.
Carol, what happened? I'm fine. Minor lacerations, probable shoulder dislocation.
Where's Kevin? Is he already here?
Don't worry, I'm gonna find him.
What's open?
Are you sure you're all right? Oh man, what a morning.
And we get our first patient. And our first patient is a 42-year-old female. She's struck by a car, and she comes in complaining of bilateral chest pain and shortness of breath. And let's take a look at how she presents.
We have to find my daughter. I don't know what happened to her. I don't know where she is.
What's her name? I'll go look for her.
Michelle Kinney.
But Mrs. Kinney, we're going to look for your daughter, but you need to tell me where it hurts.
All over my chest, and I can't breathe.
Any pain here?
No, not really.
Pulse ox is 88 on 10 liters.
Okay, poor tidal volume.
Okay, so we've got this sick trauma patient who comes in as a result of this accident in this coffee shop. She is short of breath, her pulse ox is low, and just taking a look at her, if you were taking care of a patient like this, how would you describe her appearance and her breathing?
So her overall appearance is anxious, and the temptation that people often have is that anxiety is actually somebody just being emotional. But in the case of trauma, you actually have to be concerned that the anxiety is due to physiologic stress. So a big takeaway watching this video is that she does appear anxious. She's clearly short of breath, and she has a mechanism that is consistent with the process that could result in that. Mm-hmm. And so I would be very concerned about her having very serious injuries.
Okay, so looking at her, there's concern based on her appearance and the way she's breathing. Very good. And then, in your mind, when you see somebody like this, what are some diagnoses that you're worried about in the case of trauma?
Right. So anxiety and shortness of breath, you could be worried about hemorrhagic shock, which can also produce a sensation of shortness of breath, as well as direct thoracic trauma. And she was complaining of chest pain, so there's a high risk for that. In terms of thoracic trauma, you'd be worried about things like hemothorax or pneumothorax. You could also get sternal fractures with direct cardiac injury. And this mechanism was probably also significant enough where she could have other things as well, such as thoracic arch injuries.
Okay, so she could have injured her aorta, her sternum, her heart, her lungs, and so these are all the things that sort of go through your mind when you're looking at a patient like this. Wonderful. So what do you do in these circumstances? It's obviously very scary. This person has all these potentially life-threatening, lethal injuries, some that could get bad very quickly. How do you approach someone like this?
Well, luckily, with these complex patients who could have multiple injuries, there is a pathway that's been worked out that can help guide you through the resuscitation, and most importantly, a process that can guide you to the most life-threatening injuries first, and those are the principles taught by ATLS.
Okay.
And so I would go through the standard A, B, C, D, E, where you are addressing all of those areas: airway, breathing, circulation, disability, and then ultimately exposure, so that you can identify which of those things might be leading to her presentation.
Okay. And following that approach, we look at her, she's talking, so we know their airway is okay for the moment. We assess her breathing, and that's where we might identify a pneumothorax or a hemothorax or a flail chest or some other serious thoracic injury. And then do we go on and try and figure out if there's more injuries, or do we do something? Do we address that right away?
Yeah, you have to be very dutiful to stick to this. So once you've identified a life-threatening injury, if you've identified a pneumothorax or a hemothorax, that means that you actually stop and address that. The reason why these are organized in the way that they are is that these are the things that can kill you the most quickly. So if you've identified a life-threatening pulmonary issue, then you have to address that right away. You also should not flag after you've addressed that issue, and be sure that you go through each of the other steps as well. So even if the breathing is okay, you still have to assess circulation, because circulation, problem with circulation can cause all these symptoms as well. So you have to be very dutiful about going through each of these steps very carefully and make sure you address the life-threatening issues as you encounter them.
And I think you bring up a really, really important point, which is just because she's short of breath doesn't mean it necessarily is a thoracic injury.
Right.
Patients that are in hemorrhagic shock can look exactly like this.
Right.
Fantastic. All right. Let's see what happens next.
Pressure's down to 75.
Another 2 units of ONEG. No bleeding in the belly.
Chest x-ray shows diffuse bilateral pulmonary contusions, no signs of blood loss.
Pulse ox falling to 80 on 100% oxygen.
Okay, so blood pressure's down to 75 systolic. Forgive my horrible handwriting. Chest x-ray, pulmonary contusions, and her pulse ox reading is going down as well. So patient is clearly getting sicker, but the really worrisome finding is this blood pressure of 75 systolic. So when you encounter a patient like this, recent trauma and acute hypotension, what are some things that you think about? What should we be worried about in this patient?
So in this particular case, and in all cases, when you have a person who comes in and then deteriorates, you have to start from scratch again and reassess everything. So even if you had gone through and had not identified any problems in the first pass, the fact that she's become hypotensive and is deteriorating is very worrisome when you go back to the beginning. There's a good chance her airway won't be intact. There's a good chance that she's no longer conscious. If the breathing was okay on the first pass, you might find that that's no longer the case. And in circulation, she's clearly in shock. Now, she's clearly in shock, so you have to address that immediately. And so you should be thinking about the different causes of shock in trauma patients. And the most common causes are often bleeding. And so you have to be very sure that you are assessing for all sources of bleeding. And then you have to look for other causes such as restrictive processes, tension pneumothoraces, if you have a pericardial tamponade. Spinal shock, probably a little less likely in her since she was moving her upper extremities earlier in the video, but still always a possibility that could be contributing to her hypotension.
Great, and these are the things that we think about all the time. We kind of go through this checklist in our mind. It's really bleeding, 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 and then tension pneumothorax, restrictive process like pericardial tamponade, neurogenic shock. When someone is hemorrhaging, where do you worry about them hemorrhaging?
So there only are a few places where you can lose a lot of blood to the point where you have a hemorrhagic shock that requires a lot of resuscitation. And the two biggest places are the two large cavities in the body, so it'd be the thoracic cavities, and then the abdomen. You also could have retroperitoneum, which would be associated with a pelvic fracture. And another very important one that can get missed, even though you think it would be easy, would be external bleeding. So if someone is not assessing for external bleeding, then you actually have to take an active effort to look for it.
Great. So this Dr. Staudenmeier brings up a very wonderful checklist of places to worry about patients hemorrhaging: thoracic cavity, abdominal cavity, pelvis retroperitoneum, and then we like to say on the pavement. So extremities from either from an arterial injury or something like a femur fracture, potentially you could lose a lot of blood as well.
And one that often will get people, that's good to keep in mind, is a scalp laceration. You often will get a large volume blood loss right up front, and it might actually not be bleeding for a while. So while the person is with you in the emergency department, you might not notice that they actually have a life-threatening source for hemorrhage, and it might only open up later on, potentially when you've walked away from the patient. So especially in the elderly, it's an important thing to keep your eye on.
Great point. Great point. So in this patient now, we're faced with blood pressure of 75 systolic, low oxygen saturation, and you raise all these really important disease processes. What do we do next? You mentioned reassessing the ABCs.
Sure. So you go through your ABCs and you make sure that you've addressed anything that you've encountered there. In this case, she probably would be intubated. If she had decreased breath sounds, she would have a chest tube in place. She should have large bore peripheral access IVs or central access with a cordis catheter to provide resuscitation. And she should be receiving blood at this point. And then neurologically, another examination. Then what you need to do is start using your adjunctive studies to help you identify why this person is having difficulty. And the adjunctive studies come after your primary survey because they're the other way, again, to help identify those life-threatening injuries. So you need a chest x-ray, and you're going to need a fast exam. And if there's any concern, you can also get a pelvic x-ray. We have a low threshold to get a pelvic x-ray in most trauma patients. There is a trend in centers that do have CAT scans once a patient is stable and can go to a scanner to have that replace the pelvic x-ray, but in this case, this patient isn't stable, so she probably would benefit from a pelvic x-ray.
Wonderful. Outstanding.